I'm Sana and welcome to today's lecture, which is about stress as a response, stress as a stimulus, and stress as a transaction. Today's lecture is expected to cover the following objectives. The first objective is to get an idea about stress as a response. The second objective is stress as a stimulus. The third objective is stress as a transaction. Fourth one is coping with stress. Fifth one is stress, coping and health. Sixth is coping and health behavioral pathways and psychophysiological pathways. Seventh objective is brain and neurohumoral mechanisms it controls. Let us begin with the brief idea about stress can be a response, a stimulus, and a transaction. It is essential to comprehend the underlying idea of stress since doing so helps one fully understand what stress is. It has been proposed that stress is a reaction, a stimulus, and a transaction. These stress models essentially confirm what stress is and how it manifests in people. First, the stress-stimulus model refers to the circumstances that influence how people feel stress. Second, the body's response to the stressor is the basis for the response model of stress. Third, the transactional model of stress is an assessment of the sources of stress between an individual and the environment that is treating them. Therefore, recognizing stress and its symptoms might help you prevent its bad effects. It is crucial to first consider the many ways of thinking about stress and how coping research has developed alongside various approaches to stress if one is to comprehend how people learn to cope with it. The way a person views stress affects how they react, adapt, or use coping mechanisms. Let us briefly discuss stress as a response. Hans Selye first proposed the concept of stress as a response model in 1956, and his general adaptation syndrome model included the concept of stress as a physiological response pattern. There are three fundamental components in this model that define stress as a dependent variable. First, stress is a coping strategy. Second, the three stages of alert, resistance, and exhaustion are followed by stress. Third, stress that is continuous or severe enough to cause problems of adaptation or even mortality may occur. Selye proposed the idea that stress response could have either positive or negative effects depending on how the mind interprets the physical symptoms or physiological experience in the stress concept past, present, and future. Thus, stress may be felt as either pleasant or unpleasant. Selye, however, always believed that stress was a biologically grounded construct or response. Other researchers gradually broadened their perspectives on stress to incorporate psychological ideas that were included in the stress model. The coping process is a part of the response model of stress. At both the alarm and resistance stages, the gas model, the concept of adaptation or coping is present. The alarm response activates the sympathetic nervous system to flight or flee from the stressor when faced with negative stimuli, that is, increased heart rate, temperature, adrenaline, and glucose levels. The fight or flight reaction to the stressor is then triggered by the resistance response, restoring homeostasis, minimizing damage, or more broadly accepting the stressor. This can result in adaptive disorders like sleep apnea, mental illness, hypertension, or heart disease. Thus, early research on coping was developed along with the early understanding of stress as a physiological response. In the book, The Wisdom of the Body, Walter Cannon first discussed the idea of self-regulation in 1932. Coming to stress as a stimulus. In the 1960s, the concept of stress as a stimulus was developed. According to this theory, stress is significant occurrence or change in life that necessitates a reaction, adaptation, or adjustment. The Social Readjustment Rating Scale, developed by Holmes and Ray in 1967, rates 42 life events based on the level of adjustment that an individual would likely need to make as a result of each occurrence. For example, marriage, divorce, relocation, change or loss of job, loss of loved one. According to Holmes and Ray's theory, stress is an independent variable in the health-stress coping equation, acting as the cause rather than the result of an experience. There were issues with the stress as stimulus notion despite some relationship between SRRS scores and sickness emerging. The stress as stimulus model implies that stress arises naturally from change. All people must adjust to life circumstances to some degree. There is typical adjustment threshold at which disease will develop. Ray's and Holmes' first perspective on the human subject was that of a passive recipient of a stress, one who had no influence on the intensity, severity, or emotional impact of the stressor. Ray's added the idea of interpretation to his studies later, contending that a transition or life event could be viewed as a positive or bad experience depending on cognitive and emotional aspects. The stress as stimulus approach, however, continued to disregard key elements including prior knowledge, the environment, social support systems, personality, and life experience. Let us now talk about stress as a transaction. Richard Lazarus created the transactional theory of stress and coping in an effort to explain stress as a more dynamic process. This theory sees stress as a result of a transaction between a person and his or her complex environment. When Dr. Susan Kobasa applied the idea of hardiness for the first time, stress as a transaction was first introduced with the greatest impact. Hardiness is a set of personality traits that separate those who maintain their health under stress from those who experience health issues. Salvatore, Maddie, Kobasa, and their graduate students at the University of Chicago introduced the concept of hardiness in the late 1970s. Hardiness and other psychological personality constructs such as locus of control, sense of coherence, self-efficacy, and dispositional optimism share some notable similarities. In order to account for numerous processes involved in experiencing a stressor, researchers expanded and categorized various components by adding several variables to the stress as transaction model. There are several ways to categorize stress, including acute, episodic, or intermittent and chronic. A number of stressors such as events, situations, cues, and conditions developed. These stressors were then divided into groups according to their locus of control, predictability, tone, impact, and length. Putting a person's evaluation of a stressor at the core of the stress experience, Lazarus produced an excellent synthesis of early research on stress, health, and coping in his book, Psychological Stress and the Coping Process, published in 1966. How a person evaluates a stressor affects how that person deals with the events and reacts to the stressor. A variety of personal and situational factors, including capacities, skills, and talents, limits, resources, and norms, have an impact on whether or not a stressor is seen as upsetting. In their stress appraisal model developed by Lazarus and Folkman in 1984, which contains primary, secondary, and reappraisal components, they further examine the concept of interpretation. Finding out if the stressor represents a threat is the first step in the appraisal process. In secondary appraisal, the person examines the resources or coping skills at his or her disposal for dealing with any perceived risks. Reappraisal is a continuous process that includes reevaluating both the nature of the stressor and the resources available to respond to it. Moving forward to the objective of coping with stress. People attempt to control challenges and feelings of stress in their life in a variety of ways. The benefits of stress management are widely lauded in popular and scholarly literature, and entire academics are devoted to it. There is a variety of methods that can be used to help people handle the stressors that life provides. To temporarily compensate for the biological tissues involved, some of the approaches create lower than normal stress level. Other techniques confront the stressor at a higher level of abstraction. Techniques for managing stress are more common and include cognitive, such as mindfulness, cognitive therapy, and meditation. It includes physical, such as yoga, art, nature, medicine, and deep breathing, and environmental strategies such as spa visits, music, pets, and nature. Stress coping determines whether a person believes they have the resources to adequately respond to the challenges of a stressor or change, according to the explanations made by researchers like Lazarus and Folkman. The appraisal literature has identified the responding or coping process in terms of problem-focused coping or emotion-focused coping, commonly known as active and passive coping styles. Additionally, there are approach and avoidance style coping mechanisms that involve assertiveness or withdrawal. An individual evaluates a problem when it is presented to them in two ways. First, as threatening or non-threatening, and second, as through whether or not they have the resources to properly respond to or cope with the difficulty. The likelihood of the person using an emotion-focused coping strategy such as wishful thinking, for example, I wish I could change what is happening or what I feel. Like distancing, for example, I'll try to forget the whole thing, or emphasizing the positive, for example, I'll just look for the silver lining, increases if they do not feel they have the capacity to respond to the challenge or feel out of control. If the person has the ability to handle the challenge, they will typically adopt a problem-focused coping strategy, such as evaluation. For example, I try to assess a situation to better understand it. I am creating a plan of action and following it. It is hypothesized and empirically proven that someone's secondary evaluation determines their coping mechanisms. The COPE inventory is one of many tools and scales used to measure and test different coping mechanisms, which range from optimistic thinking to denial. Let us now discuss the fifth objective of today's lecture, which is stress, coping, and health. The ability to thrive, be resilient, or grow as a result of stress has been linked to better health outcomes. For instance, Shepard, Morato, and Robert discovered that optimism predicts success in implementing health improvements linked with a lower risk of cardiac disease in their longitudinal study of cardiac patients, expanding on Carver's work on dispositional optimism and thriving. Optimism was favorably correlated with success in enhancing aerobic capacity and significantly and directly correlated with improved health outcomes, including reduced levels of saturated fat, body fat, and overall cardiovascular risk. Among men who were providing care for AIDS patients, Billings and colleagues, research developed that coping affected both positive and negative effect. Lessening of physical symptoms was associated with improvements in good effect, which were predicted by social support coping. In contrast, avoidant coping was linked to increases in negative effect, which were linked to increased somatic symptoms. The majority of coping research so far has been on psychosocial outcomes like mental health and life satisfaction, or on physiological reactions that take place very early on the path to sickness. As a result, there isn't much that can be said about how coping affects health in general. However, some of the negative impacts of stress on health are now much obvious. Moving forward to the objective of coping and health, behavioral pathways and psychophysiological pathways. First, we will talk about behavioral pathways. Although a lot of the discussion on coping and health focused on the physiological reactivity that comes with distress and the illness pathways that follow from that reactivity, there are also easier and more straightforward ways that unhelpful coping can lead to health issues. Particularly, some people deal by engaging in harmful behaviors. We briefly discussed this path to illness before moving on to our topic of coping and health. There is a lot of variation among the reactions that fall under the category of emotion-focused coping in the context of differentiation between problem-focused coping and emotion-focused coping. As we stated earlier, emotion-focused coping can legally refer to almost everything a person does with the intention of lessening distress. Some of these reactions themselves have unintended consequences. Some can in fact worsen health issues. To self-soothe or manage emotions when stressed, for instance, people frequently smoke, drink alcohol or drugs or engage in casual sex. These actions may lessen unpleasant emotions in the near term, acting as emotion-focused coping. In the end though, they might be harmful to your health. Doing behaviors that are harmful to health is a component of maladaptive coping. It involves a partial abandonment of health-promoting habits. To preserve excellent health, it's crucial, for instance, to keep up a regular exercise schedule and a well-balanced diet. However, the first things to go when stress strikes are frequently healthy food and exercise. The individual loses out on incremental benefits that might otherwise occur if these health-promoting practices were abandoned. This means that giving up those healthy habits can be viewed as unhealthy coping. Let us talk about psychophysiological pathways. Despite these clear behavioral links to the health, the majority of discussion of health and unhealthy coping focus on long-term development or suppression of physiological changes. One could concentrate on a few levels of abstraction when addressing such consequences of stress and coping. The focus may be on irregular changes in an immunological or endocrine parameter, the onset of a disease state, that is in between other disease states like atherosclerosis, or the eventual appearance of full-blown clinical events like heart attacks. Research at each of these levels have been studied. The stress hormone cortisol is one group of physiological indicators that has drawn attention. According to various studies, problem-focused and approach coping styles are associated with lower overall cortisol levels, more favorable diurnal cortisol rhythms, and quicker recovery to normal patterns following a stressor. Positive cortisol profiles have also been associated with a number of characteristics that represent social integration and support. According to O'Donnell et al., using social support is associated with lower daily cortisol levels, a higher cortisol response upon awakening, and a higher cortisol output during the day are predicted by social isolation, living alone, and having little interaction with friends and family. Even after adjusting for social support, women with fibromyalgia have shown that higher levels of religiosity are related to positive cortisol patterns. Variations in immune system performance have also been connected to coping strategies. An immunological marker linked to the development of HIV disease, for instance, was higher in HIV patients who had trouble identifying and expressing their emotions. Additionally, among HIV patients, disengagement tendencies were associated with higher viral loads and poorer immune cell counts. In a sample of individuals who were not patients, instrumental coping was associated with decreased HPA activation and improved immune system performance. Atherosclerosis is a different intermediate physiological condition that has gotten a lot of attention. Atherosclerosis and stress are topics that are well known, but coping skills are less well known. In laboratory animals, even minor chronic stress increases the risk of atherosclerosis. This process appears to be mediated by HPA activation as indicated by higher stress hormones. According to Libby, inflammatory immunological responses brought on by stress are essential for the development of atherosclerosis and serve as a mediator between stress and the disease. According to studies, prolonged professional stress reliably predicts hypertension and atherosclerosis. However, chronic social stress can potentially have a comparable impact. For instance, in monkeys, both social isolation and overcrowding contribute to atherosclerosis. Social disruption and atherosclerosis in humans have been associated in similar ways. Coming to the last objective of today's lecture, which is the brain and the neurohumoral mechanisms it controls. The close interactions between the several processes of the brain are the foundation for how stress and coping with it affects physical health. In addition to controlling physiological activities like breathing, heart rate, blood pressure, and a number of metabolic processes, it also plays a role in perception, the highest level of reasoning, emotions, and urges. These mental processes are very closely tied to one another. As a result, the perception and thinking that lead to the conclusion, for example, my child may have cancer, evoke intense fear that makes one's face pale, blood pressure rise, digestion stops, and impairs one's ability to think clearly about other issues. These are some of the physiological processes that underlie various forms of stress, most notably the flight or fight response. A few of these mechanisms may provide a feasible logical justification for some of the empirically observed somatic effects of psychological stress. They may also serve as a useful guide for the kinds of studies that may help us better understand these effects. The pituitary adrenal axis related groups of processes are among the best researched. The pituitary gland releases adrenocorticotropic after being stimulated by corticotropin-releasing factor released by neurons in the median eminence of the brain, and this in turn triggers the production of glucocorticoids, commonly known as corticosteroids, into the blood by the adrenal cortex. These in turn shut down the release of CRF from the median eminence, closing the negative feedback control loop. The negative feedback mechanism is bypassed under some stress conditions, such as fear, probably through neuromechanics. As a result, substantially higher levels of adrenocorticotropic and corticosteroids are released. The body's ability to adapt to physical stress is greatly facilitated by corticosteroids. Because of their anti-inflammatory properties, they can be used to treat conditions like arthritis. They aid in stabilizing lysozyme membranes inside the cells to stop the diffusion of harmful hydrolytic enzymes following damage. A patient with significant corticosteroid deficiency who undergoes major surgery or suffers a serious accident will pass away from abrupt vascular collapse. Corticosteroids can be administered to stop this deadly collapse. In 1956, Sallier demonstrated that one of the initial responses to physical stressors such as surgical injury, cold, and sublethal injections of formaldehyde is the stimulation of the pituitary adrenal axis, a phase he refers to as alarm. With continued exposure, the corticosteroid levels may be reduced during a phase referred to as adaptation, but with too great an exposure, the physical symptoms may reappear and the mechanisms involved in chronic stress have not been as fully researched as those involved in shorter durations of stress, so further research is required. Patients who get corticosteroids for their anti-inflammatory benefits may have a range of adverse effects. They can prevent or worsen diabetes by interfering with insulin's ability to work, as well as cause peptic ulcers, calcium loss from the bones, growth inhibition, irregular menstrual cycles, and hypertension. However, in some of these cases, the consequences of corticosteroids may be confounded with those of the ailment they are being used to treat, such as extremely unpleasant arthritis. While the mentioned effects of corticosteroids are often seen with pharmaceutical doses, the fact that stress can cause similar effects makes it reasonable to look at the potential contribution of endogenous corticosteroids to these effects. The mobilization of fatty acids from adipose tissue and other processes related to energy metabolism is also mediated by corticosteroids. Strong sympathetic nervous system activity is a component of both fear and the acute flight or fight reaction, which Cannon examined. The sympathetic nerve terminals release norepinephrine during such arousal, while the adrenal medulla releases epinephrine into the bloodstream. When combined with corticosteroids, these catecholamines help mobilize fat reserves. Lipid levels in the blood may rise as a result of this. These fatty free acids may boost the synthesis of very low density lipoproteins in the liver if they are not burnt off by muscular activity, which may then promote the growth of vascular smooth muscle cells and the onset of atherosclerosis. The catecholamines also make the blood more likely to clot, which helps to stop bleeding after injuries but may potentially play a role in the development of blood clots that obstruct arteries. The catecholamines can constrict arterioles by causing platelet aggregation at large concentrations. Similar platelet aggregations have been seen in rats who had their feet repeatedly shocked with electricity to stress them out. High sympathetic arousal also raises the heart rate, stroke volume, and hence cardiac output. In particular, if no action of the major skeletal muscles is occurring to reduce their resistance, this results in an increase in blood pressure, which is further compounded by an increase in peripheral resistance that is likely to occur. Additional impacts of stress include increased thyroxine secretion, suppressed prolactin secretion, which interferes with milk letdown, and perhaps decreased levels of testosterone and estrogen. A state of emotional arousal increases skeletal muscle activity, and an increase in cardiac output that is directed away from the skin and viscera and toward the skeletal muscles, where vasodilatation lowers the peripheral resistance, are the hallmarks of the flight or fight response. Williams in 1975 has drawn attention to the existence of a distinct pattern, which he refers to as a state of vigilance. In this condition, skeletal muscle, skin, and viscera all exhibit active vasoconstriction, which increases peripheral resistance. Motor activity and heart rate also drops. While little research has been done on such possibilities, he thinks that this second pattern may also cause cardiovascular disease. The physiological processes involved in persistent psychological stress and the recovery from stress are other areas that have received comparatively little attention. The majority of neurophysiological processes are regulated by both excitatory and inhibitory mechanisms. Even though the parasympathetic nervous system's actions frequently conflict with those of sympathetic nervous system, their relationship goes well beyond mere reciprocal inhibition. Stress can simultaneously activate parts of the parasympathetic and sympathetic nervous system. Alternatively, it might tip the scales in one direction before moving the other, as when anxiety causes the heart to race due to vagus inhibition or causes the heart to skip a beat due to vagus stimulation. These paradoxical contradictory effects highlight the need for more research to more precisely identify the circumstances in which the effects may be in one way or the other, including investigations of dose response, temporal response, and interactions with other variables. They also warn against applying results from one case to a potentially unrelated one. Brain regions that block pain have recently been identified. These tracts include morphine-binding receptors as well as compounds that resemble morphine and may behave as neurotransmitters. Since morphine also lowers fear in addition to pain, there is a strong likelihood that this route inhibits both fear and possible external stress. The effects of anti-anxiety medications also imply that the brain may have unique receptors and pathways that are more particularly involved in the inhibition of fear. Although the neurophysiological systems that have been addressed seem to be capable of creating a range of somatic consequences of stress, in most cases, the precise mechanisms that are actually engaged in specific impacts of certain stressors or specific coping methods have not been established. Such an assessment ought to be a fruitful kind of research. This brings us to the end of the topic. Thanks for watching.